All right.
Are you sure?
Yeah, we're going.
Because I can pull my.
Okay. We need to approve the August 22nd meeting note.
So move.
Second.
All in favor?
It's like I'm already paying.
Anyone opposed? Okay, at some point, John, I think we will need updates on what the Alliance will be doing. Because that was in the minutes, okay? We also need to approve the August 26th consent agenda. Any comment?
And then we approve the consent agenda.
Second.
All righty, all in favor? And anyone opposed? So the executive committee did John Forte's evaluation, met with him. He agreed with it, signed it. Jim Harris brought to my attention that we should bring that to the full board, which we will plan on doing in executive session next meeting. So John, you're up.
All right. Good morning.
Morning.
Joining us this lovely September morning. Couple administrative updates. First, not on the sheet and in the packet yesterday. I had a great visit by Attorney General Knudsen and received $10,000 from the Department of Justice and the AG's office. It's part of the Johnson & Johnson Baby Powder Settlement Fund, which there's over $1 million in. The first 10,000 was delivered to us yesterday. It'll allow us to buy some equipment and help us fund our childhood advocacy center work. The team did a great job yesterday at a press conference and then giving tours to several legislators and Department of Justice staff. So that'll go to the Yellowstone Valley Childhood Advocacy Center, which is a cohort, a coalition between ourselves, local law enforcement partners, our hospitals, and other partners across the community. So we're going to continue to grow our efforts to meet the need, unfortunately ever increasing need, of providing child abuse and child maltreatment care here at RiverStone Health for this community and our region. We serve most of eastern Montana. We are the last CAC on the frontier moving eastward. And so folks come here when they're in need. We also had a couple of weeks ago our HRSA site visit, our operational site visit for the clinic. That's our federal visit. Make sure we're coming in and being compliant with all federal regulations as it reports to our federally qualified health center. The team received a perfect score. There were 0 findings.
0 negative, there were positive.
There were positive findings. There were best practices identified as a result. And so we had 0 negative findings on 94 particular elements of performance, which means we were only the 3rd out of 50 of these inspections done by our federal colleague who was here with us. We were only the 3rd perfect one that was identified with 0 non-compliant findings. But they did recognize several best practices about how we integrate students and learners into our teaching health center, our transition of care team, our focus on well-being and wellness for not only our staff, but also our patients, critical incident debriefing, as well as a quote, pristine, unquote, credentialing and privileging process. So kudos to our credentialing and privileging team at the clinic. So all good news there. We did have a retirement last week. Vicki Solzer, our manager of school-based health centers and rural clinics. She retired after 14 years of service to RiverStone Health. So while we're sad to see her go, I'm very thankful for the program that she's built and the strong foundation she's given us with the schools to continue school-based health growth across the community. And we have already hired her replacement, and she's onboarding this week. We, just in case you have any children out there that need grief support, our next Brave Hearts Grief Support Group kicks off this evening, which is a great program through our home health and home hospice programs. And then I know many of you were here, but on Monday, September 9th, we officially unveiled the Robin and John Felton Community Garden at RiverStone Health. So just been a great opportunity to remember the legacy and the commitment of the Feltons to this organization. And just a great photo captured there by our own Casey Page. Other good home hospice news. We had a patient make the front page of the Billings Gazette the other week. Just an awesome opportunity. I want to thank our social worker, Noel, for getting Jerry out there with the Dream Foundation. And they provided him with the helicopter ride. Checked it off his bucket list so that he could get out there and fulfill his dream of flying in a helicopter once again. Outreach to Medicaid patients continues monthly. We've had a small fluctuation in attribution with a drop again in August. Working with our teams to make sure that every single uninsured patient gets to care management, to make sure that we can verify their eligibility for Medicaid, help them apply, or also help them apply for a marketplace plan. So we are going to continue to drill into our Medicaid attribution data, as well as the application data, which we have seen skyrocket here in Yellowstone County. The number of folks applying for Medicaid has gone through the roof. And so we know that there are still some backlogs with BPHHS and processing. And I don't blame them because just so many people reapplying for coverage now that they lost it. So we'll continue to monitor that and help folks get back on the rolls that need to be on the rolls. Coming up next month, on October 7th, 8th, and 9th, the Big Sky Economic Development Upstream Strategy Partner Business of Healthcare Summit will take place at the Northern Hotel. So we have opportunities to talk about behavioral health education on the 7th. And so all of that is Student Day. They've invited all students, medical students, residents from across the region to attend on the 7th to receive continuing health education credits on behavioral health practices. And then the 8th and the 9th are 2 days focused on the economic impact of behavioral health, becoming more mindful about mental health in your own small business, as well as the economic impacts of healthcare to small businesses across the region. So we'll have a special session on the 8th in the afternoon on Medicaid redetermination, reauthorization. And Ed Buttry will be joining me on the stage for a fireside chat, which is going to be really important as we try to reclaim the fact-based narrative around Medicaid expansion. There was a lot of misinformation shared at a state level hearing last week, and we need to correct the facts about how Medicaid benefits our state, our local businesses, our local economy, and that this is not just some self-serving thing that hospitals and health organizations are needing. This is an economic issue. This is a livelihood issue for everyday Montanans. And so Ed Buttry is going to come join us and we'll share more of the facts on Medicaid reauthorization.
And he is in that.
Hey, John.
Yes, Senator Buttry or now Representative Buttry from Great Falls. Yes. And he's the
Hey,
original.
John.
Of the Health Act. So on Friday, September 6th, we finally met to reengage the alliance. And so here's your update, John. We were focusing on key issues that are impacting health and well-being here in Billings and across our region, with a specific focus on behavioral health needs, trying to help with the crisis continuum of care. As of a week or two ago, we no longer have a crisis response unit, mobile crisis here in Yellowstone County. Rimrock has needed to pull out due to some issues with reimbursement and operating that program. And so we're going to take a leadership role in working with this county and the city on figuring out how do we move the mobile crisis forward, provide that resource to our region, as well as some other issues related to behavioral health and how to getting folks beds and a place to go when they need a place to go, not just end up in a detention center or back on the street. So we'll continue that conversation on a quarterly basis with our alliance CEOs and several other folks sitting around the table. We had an opioid awareness day event at Rose Park, which was well attended. And then last week, I'll give you an update on our Joliet, Montana clinic. The clinic board voted to explore a lease option for temporary space, which will allow us to own our own destiny down there in Joliet. And so we will not be leaving the town of Joliet. We will stay right there in high visibility right off 212. That'll allow our folks down there to continue seeing patients while we finalize plans for a better space in Joliet.
Is that
So John, explain the shots and shots.
I will do that in our governance meeting later. But some health departments and community health centers work with urban barbershops to reach and provide health equity. We're going to be located right next to a local drinking establishment and watering hole. And so I think we have collaborative opportunity to do some unique public health work. Let's see, last month, RiverStone Health Foundation, thanks Megan and Sarah and team, provided 72 backpacks of school supplies to Orchard Elementary students and their families. We had a great event in Orchard, provided those backpacks as we have continued to do since 2015. So we'll continue that effort and get backpacks out there with school supplies for students in need. We also had our the first air quality day, unhealthy air quality day, a couple weeks ago, September 10th. And so we activated our air quality plan, sent out notification to schools and several childcare facilities. We can always do better. So we also did a hot wash after this and realized how we can be better prepared when the smoke blows in to share notification and updates on a more rapid level. So we did send out some information, talked about the risks to sensitive groups when we have unhealthy air quality days. Folks with asthma, children, pregnant individuals, and other adults could experience more serious health effects due to unhealthy air.
Where do we get our information? Is that from the state?
So we have several air quality monitoring sites that we own and operate and help with the state here in the county as part of our air quality role in public health. One is over in Lockwood. There's a couple throughout town. So we get that real-time data. That real-time data is translated through the state DPHHS website. And is also publicized on airnow.gov and other resources out there. Everybody's iPhone, if you have an Apple Watch now, it's the air quality information you can put right on there. And all of that real-time data comes from our monitoring sites in partnership with the state. There are also private individuals who have full air monitoring sites across the community. So all of that data gets aggregated and reported out. From a public health officer perspective, as the summer ended, so did our most recent crypto outbreak. Cryptosporidium it causes GI illness in individuals, and so we had several folks get sick, almost just over 100 folks between confirmed and probable cases. But as swimming pools closed and folks weren't swimming in the river and the lakes, the outbreak also subsided. So we continued monitoring because this illness can show up 2 weeks after exposure. But it's safe to say now that our summer spike is over with crypto, and we don't expect any additional crypto cases moving forward. We also saw, per your request on COVID-19 last month, we did see a summer spike nationally. That spike also led to a spike here locally. The number of COVID-19 cases remains low, but special populations, those who are immunocompromised, older adults, as well as younger children, are still at risk. COVID-19 is still out there in our community. It can still lead to severe illness and death. And while that remains low in our community, we'll continue to monitor that. But know that the best defense against COVID-19 is obviously the new vaccines that are coming to market. Same with the flu. While we've yet to see a significant flu infections across Montana, we are starting to see it across the United States. The flu season is here, and DPHHS will begin reporting weekly flu levels to us in 2 weeks, Friday, October 11th. We'll start getting data, and so I'll bring that to our October board meeting. And you'll also have the opportunity to receive your flu and COVID vaccinations at our October board meeting. And so we'll bring vaccines and staff to the board meeting so that you can all have that available. I just ask that if you're interested in that, and we will send out a reminder, please bring your insurance information so that we can collect reimbursement for that flu shot or COVID shot. No cost to you individually. Your insurance covers it, but it's a great opportunity for RiverStone to get credit for providing that vaccination. So we expect to see an average flu season this year, which is good news. We get that information and kind of get the crystal ball from how flu reacts in the Southern Hemisphere every year. And the good news is that the flu vaccine that has come to market has been proven decently effective against this flu strains that are out there, most common. And we know that because of how it's interacted with folks in the Southern Hemisphere. We also had a minor pertussis issue back in June and July, and I wanted to provide you with updates on that. We had 2 confirmed unvaccinated pertussis cases, and we had 5 probable pertussis cases here in the community. They were also all unvaccinated. The 3 household contacts that did not have symptoms and never had symptoms were vaccinated. So the proof is in pudding on pertussis, on basically all of those childhood vaccines that we have asked folks to get for millennia, years, since they've come out, that they are highly effective, that they work. Tdap, MMR, all of those wonderful childhood vaccines that eradicated polio, that eradicated disease in this country, Because of misinformation, because of a lack of facts, we are seeing a increase in the number of unvaccinated children and the number of unvaccinated adults that are living in our community. And that poses a risk to the public's health. So the best thing that you can do to protect one another, to protect your neighbors, to protect your children, is to receive those vaccinations and keep everybody safe. We are seeing measles outbreaks across the country. We are seeing pertussis outbreaks across the country. We are seeing chickenpox make a resurgence. And that is all because of the anti-vaccination movement that is out there, spreading misinformation about the safety and effectiveness of these vaccinations. So the best thing to do is to get that shot. I'll get off my soapbox.
Thank you.
Appropriate soapbox for a health officer.
Hey, John, Steve has his hand up.
Hey, Steve.
Hey, thank you. Sorry, traveling down I-95 and out of
Did you have
Washington
anything
DC.
else, John?
Quick question for you. On
And there's
going
Steve
back,
speaking, but you can't hear him.
can you hear me?
Oh, there you are.
Now.
Oh, there you are. Oh, there you are.
Can you hear me?
Go
John,
ahead.
can you hear me? Okay, so
Yeah.
on with
Speak up.
Butchery and with the Medicaid expansion, what else is planned throughout the state? Because having Ed down in Billings is good in the exposure, but it's this is a statewide. So is RiverStone, or is there an organization that is looking at the statewide education, merchandise, or marketing of why Medicaid expansion is needed?
Yes. And I'm going to mute you so we don't get background.
But
Would you repeat what you just said? I didn't.
the short answer, so Steve asked the question, is there a organization across the state that is taking the lead on educating all Montanans and all local communities about the benefits and the facts surrounding Medicaid reauthorization? And the answer is yes. There are several organizations out there leading that charge. One, and first and foremost, is MHA Association. Second, MPCA, the Montana Primary Care Association. Our local economic development folks, as well as other communities and their economic development drivers. We're all taking an all hands across the state approach on how we communicate to our local legislators and share information on the benefits and the risks.
Right.
John, on the Johnson settlement, it seemed like the paper said it was $3.5 million. And it would be paid out for a period of years, that's right? A certain number of years, and who's in charge? Who makes that decision? The state health department?
So the AG has full control of this funding, which is the exciting part for us and the childhood advocacy centers across the state. And so he has the reign on that fund that has come into the Department of Justice. And he is personally dedicated to helping fund at a sustainable level. Also work on legislation to sustain the efforts of childhood advocacy centers. So, each center is going to get an initial bolus of funding, and then they're working out right now a way to disperse the rest of that funding out based on needs.
I think I was just at a CAC meeting, statewide meeting on Monday and Tuesday, and I think it's probably going to be some sort of grant process is what was sort of shared. And the money only went to accredited centers, which is great. There are 9 accredited centers. I think the challenge is that these are very costly systems to run, and the smaller you are, the more costly it is in many ways. And there's not as much, in these smaller communities. So you have to have certain elements to be able to be accredited. Medical is one of them. So Bighorn, for example, has a CAC. It's not accredited because they don't have a medical provider to do their exams. And they really don't have a capacity to pay a medical provider. So they send, they're hoping that they're going to be able to send those patients up to our medical clinic when we get started. But what's going to be challenging is like there's no mechanism to pay for that. And so it'll be interesting to see how this rolls out. I think we're going to have to figure out a way to have more regional medical coverage. And I'm hoping that that's what we're going to be able to build here, is to be able to be the regional, but also to figure out some way to get compensated for that. Because right now our CAC is funded through county money largely, and through some grants, some VOCA, grants that we get, but it largely comes from our county. So we need to figure out how we cover those out of county costs.
Was that discussed with the Attorney General then, those issues?
A little bit. I mean, we chatted, we didn't get into details, about that. I had some side conversations with his aide that was here. Yes.
Okay.
I chatted a little bit.
Chief staff for both here.
Okay.
Yeah. But I think we need to have some more of those types of conversations as they look at how they disperse the rest of this,
Alex is a local guy.
Yeah. He went to West, didn't he? Or he taught at West. So, yeah.
Yes. Willis too. Yeah, they both.
Will taught.
Yeah. But yeah, no, we had a good conversation. Senator Lenz was here as well, and had a good conversation on how do we bring something to the legislature this session that helps with sustainable funding, but also prevention. And how do we avoid getting in, getting families caught in this cycle of sexual abuse and trauma, and focus on solutions.
Senator Lenz would be a good
Right, he's there.
Yeah.
in contact.
Yeah. Thanks, Megan.
Anything else for John? Megan, you're up.
All right. My report was included. I think pretty much everything's been covered. I'm happy to expand on any of it. We're, as far as provider staffing, we've successfully hired. I had mentioned previously that we were using locums to cover our inpatient services to help shore up that shortage. And one of our locums, it's hard to do locums in a teaching environment. Like typically locum physicians are physicians that, just travel and work, don't really want to have strings attached and kind of just travel and work. And our system is very different because we're relying on them to also teach our residents, and not every person who practices medicine wants to teach. It takes some special qualities to want to do that. But we found one that was working really, really well, Dr. Swayze, and she was a regular locums that was working with us, and she has now joined our faculty. So she has joined our faculty. We are not going to be using any, we feel like we have enough inpatient coverage to not have to, partly we have enough inpatient coverage. What's more is that we really struggled with a lot of the other locums that we had that I think our faculty are at a point where they would rather just figure out how to cover, and with Swayze coming, that will help offload some, that we're not going to be using locums. any longer for a while anyway. We're having some shifts in our APP structure. I think that I sort of outlined. We're working on recruiting. Our big absence is going to be a provider and warden, because our provider, it's hard to send. We get a lot of applications with brand new grads from APP school, but we don't want to send a brand new grad out to a site where they don't have more direct supervision and support from other people. And so we really want someone to be in training in practice in primary care for at least 2 years before we send them out to a satellite site. And so we're going to be pulling people from here to go cover warden until we find an experienced provider. We've also posted another position in hopes that we'll be able to get, we have a number of new grads, like I said, who apply. And so we can bring a new grad in here and then figure out how to get warden, and also Joliet and Bridger covered, because our provider out there is cutting back. Other than that, we continue to really, the school-based health center, I think Eric is going to be presenting on that model later on today. We are expanding to, we were the second school-based health center in the state. And now we're expanding to senior this year. So that's really this month, actually. So that's really, really exciting. I did want to give a shout out to Vicki. Vicki covered a number of services here. When I first came here, she was actually the nurse at the Montana Women's Prison back in the day when we were doing, prison and incarcerated medicine. And so that was sad to see her go, but I think we're really excited about the energy that Nicole this week. And I think we're really excited about the energy that she's going to bring. We're still really trying to work through what's the right balance with the reduction in workforce that we had, trying to figure out how we get enough coverage to cover providers. We have had to pull providers out of clinic because we haven't had enough staff to cover them. And so we're trying to figure out, and part of that is due to FMLA and other leaves within our support staff. But we know that we're always going to have FMLA and leaves and support staff. And so we're trying to figure out what's the right number of support staff to have so that we don't have too many extra when we have the swings and providers due to the teaching health center model that we have, but enough to cover those high points so that we're not having to shift providers to other administrative tasks and not seeing patients. So we are working on that. And then I think we covered everything with a child advocacy center. The one thing I will add is that our CAC here really does mostly sexual abuse evaluation. That's not necessarily the case nationally. Nationally, a lot of child advocacy centers do a lot of the physical. They're sort of the consulting team for the physical abuse. Physical abuse is way more common than sexual abuse. When you look at the statistics of abuse and maltreatment, 76% is neglect. And then physical abuse. And so by and large, neglect is the most common form of maltreatment. And then you have physical abuse and then sexual abuse. And so we're really looking at how we can become we are missing a lot of child abuse, physical abuse in our communities in Montana. The most common sentinel injury, initial injury in a child who has significant consequences from physical abuse is a bruise. And those often go undiagnosed as abusive injuries. And then when we have these really horrible, catastrophic child abuse cases, when they come back, we recognize that they had presented to the healthcare, and had a bruise identified previously. So we have a lot of education to do. We actually are going to be sending out some messaging in October on that bruising. So there's a mnemonic 10-4 faces and P, 10-4 faces P, and it's a mnemonic that helps you to identify concerning bruises. And we're going to be sending out, so the AAP nationally is trying to make October 4th, 10-4, sort of a recognition day of child abuse. I think the Missoula mayor is proclamating that as their mayor real proclamation day. I think it's on Gianforte's desk, but I'm not sure he's going to get to it. We did not approach our mayor this year. We sort of had thought about doing that, but then we had a lot going on, so we didn't do that this year, but perhaps next year we'll sort of get on top of that. But we are going to have information out. So we're hoping, that we're going to be able to sort of expand that area in our child advocacy. Other than that, I am open to questions.
I don't have a question, but I would just wanted to put a plug in for the residents. I did a elective rotation with one of the residents, and it was pretty awesome. Hopefully that person learned. Basically, they came and they hung out with me for a week. I think he came from like 2 to 8 every day, and it was enjoyable and hopefully beneficial. It was a decent rotation. So hopefully, I don't know if you're interested in adding that as a radiology kind of elective, but
Yeah.
Anyway,
Yeah.
I don't know if you had any feedback. I have no idea.
Yeah, I haven't heard any feedback, but I'll look into that. That's exciting. We love more teachers.
Thanks for doing that.
Yeah.
Was there any chocolate involved?
Actually, I gave him a chocolate bar every day. We did a chocolate tasting and stuff like that. But,
What did he give you?
he actually, the last day he gave me some cookies, cookies or whatever. Yeah.
Okay, we're up to finance. Jim.
Thanks. You have two things in front of you. You have paper, financial statements, and Katrina's memo, please. And in the financial statements, I'm going to the third page, which is my habit, to look at cash. It says statement of cash flow, July 2024 financial report, statement of cash flows. I always glance down through this to see what is actually coming in. So the first little block down to total cash received, that's the cash that came in the door from various sources. Then the next little block, 3 lines are disbursements, cash going out the door, except for capital purchases. Capital purchases would be assets that last more than a business cycle. Pieces of equipment, furniture, a building, automobile, something like that. Then cash provided or used in capital activities. So capital activities can provide cash if you sell an asset or consume cash if you buy one. And then I go see the net change in cash. And it's 634 grand for the month, positive cash flow. That's a good thing. For bean counters and non-bean counters alike. The two numbers below that net change in cash show you cash at the beginning of the period, which would be July 1, beginning of our fiscal year. So close of business, June 30. Janet put the dipstick in the bank accounts and we had 7,062,000 change in those bank accounts. Operations provided an additional 634,000. Does that all make sense? All right, so if I look at Shanna's memo, she says, okay, her first bullet point, right, when you want to challenge yourself preparing for this meeting, or if you're having insomnia the night before this meeting and want to be on your toes, pull out this memo and the financial statements. Go to a couple of these bullets and see if you can find them in the financial statements. First one says cash total 8.6 million. And other than committee members or Carol, where would I find that 8.6 million on the financial statement? It's an asset. Where is it, Carol?
It's on, well, it's in two places. It's on the balance sheet and it's on the statement of cash flows.
So if I look.
Do I win anything?
Yeah, you get chocolate with Ann.
Oh, yay.
You get to do a chocolate rotation. with Ann.
Yay.
So if I look at the balance sheet, which is the first page of the financial statements, July 2024 financial report balance sheet, those top three lines, operating cash, cash on deposit with the bank, the total of those two is approximately 8.6 million. Okay? And remember when I walked you through a balance sheet, that the encounters do the organization of that balance sheet intentionally to be decreasing liquidity through those assets. The most liquidity is how fast an asset turns into cash. So cash is the most liquid, and it is the first one presented on the balance sheet. The second bullet point on Shanna's memo. At the end of July, deferred revenue totaled approximately 2 million, consisting largely of COVID. At 1.7 payments for COVID, restricted COVID funds need to be spent by the end of 25. It's something I've referred to many times in a presentation of these financials. You find where that is in the financial statements. Where is it, Carol?
It's on the balance sheet under liabilities, line number 3. This is good, Jim. We've got a good thing going here.
Cool, friend. We're
Yeah.
right on.
Hey, Carol, it's nice to know that at least somebody besides Jim understands.
Okay. Yeah. But he's on the committee.
I'm on the committee.
Yeah.
Yeah, that, excuse me, I can't give away the answer.
So that is when I say we've got this money, but what it needs, it's restricted, has to be used for a COVID associated expense or something that the government would associate with COVID. And they are loosening the strings on that, making it easier to use the money. Staff can tell you some of the things we're looking at, but it's a big chunk of change to work through in the next year.
John, do we have a team looking for things?
We do. Multiple teams. Looking for multiple things.
Then I'm gonna pull both down 4 more bullets on Shanna's memo. Patient service revenue. Where would I find patient service revenue in these financial statements?
Spencer?
On the statement of
Statement
revenue.
of,
You flip to the second page. The third, fourth, fifth, and sixth line. The top of the page under operating revenue, it says Medicare, Medicaid, insurance, self-pay. Those are the per se guarantors, categorization, guarantors for patient services. So I harp about patient volume driving so much of the expense and so much of the revenue in that half of the business that is patient service related, not the public health half, the patient service half. That's where the revenue is showing up. It's a very unpredictable number because you can't predict patient volume. We don't know how many will present today. Okay. One more, the last bullet point on the first page of Shannon's map. Financials represent a net revenue totaling approximately 387,000. So Spencer brought us to the statement of revenue. Net revenue would be on there somewhere. Oh, Spencer, look, the bottom line. Oh, it's referred to sometimes as the bottom line. 387,000. That means operating and non-operating activities on an accrual basis or revenue is recognized an expense that month. Being the kind of bean counter I am, I always hold up a third of the way to net operating income, which is, that's for 50 years, whatever period of time I've looked at these things, that's the number I naturally go to. It's the result of operating activities. If operations provide sufficient revenue to cover their expenses. Okay. That's it. Thanks for bearing with me on this. That's yourself. It's on the X for people who want to challenge me. Any questions?
That's a good one.
Go ahead, Sean.
Yeah, there's just a typo in the notes on the increase in cash. It wasn't 634 million, although that would be great. Maybe soon.
Yeah, it's 6,033 million.
Did you have any other comments?
No, I think just around the cash, it's something we're monitoring really closely, organizationally, just because it speaks volume, right? You can see what cash is doing. And so looking at that daily and seeing an increase from June to July is definitely hopeful, because normally we see kind of a normal cyclical flow in the cash with the payment of our property tax, one half of it in June, and then kind of just a decreasing trend through until the next payment. So seeing cash actually increase in July was a good sign.
Anybody else
I
have?
have a question. You commented about collections of bad debt. Have you changed some things too?
So we've worked through a lot. There was a lag within the organization on collections of bad debt. And so we worked through a lot of that last fiscal year, just knowing that the fiscal year wasn't going to be very good. So just writing it off and getting that clean. And so now we're a year out on those collections. So we're sending anything older than a year to collections. And we actually had a conversation at Finance Committee if we should shorten that up a little bit. So we've got the capacity to do that within our department, and just getting that. I mean, it makes good sense because some of the stuff that was so old, obviously you're never going to collect, when it gets past that year mark. So, yep.
Do you send things to a collection agency after a certain?
Yeah, we
time?
use a collection agency.
Okay.
Anything else? Okay. We need to accept the August 19th meeting notes with the correction on the typo.
We accept those. Second.
All in favor? Anyone
Aye.
opposed? Thank you, Steve. Then we need to accept the July financial statements.
Except July.
Second.
All in favor?
Aye.
Anyone opposed? Okay. Final time here. The notes that came in the packet were quite extensive, and I think really showed what is now going on and is a real reflection on how the restructuring has really improved that. Brent, comment? No,
Like you say, good report.
there was a super shared learning
Hello?
story.
There's Lionel.
Lionel, would you speak?
Yes, no, I am here. I'll try. I am on the road between Gillette and Spearfish, so hopefully my signal hangs on here. As far as the committee minutes, we had
Lionel,
a
if you speak up, it
fantastic
would help.
presentation. I'm trying to speak up. Can you hear me now?
A little
Can you
better.
hear me now?
We're turning up the volume.
Okay. Okay. So we had a presentation on our cybersecurity, essentially. And it was a very sobering presentation. And Michael Dennis and I were at the meeting, and we requested that this presentation be given to the full board in an abbreviated form. But we learned about all of the attacks that we are actually receiving on an ongoing basis, and what our IT folks have been able to do to really protect our data in our organization. So that was the gist of the meeting. Other than the second part was that we have now moved our electronic medical record from a system that's hosted on the one of the floors above where you are now into a cloud-based system, so that it would be more protected and less vulnerable to local shutdown. So that was primarily what we talked about. And hopefully the rest of you will hear this fascinating and important topic coming up here soon. John, is any other comments?
No, Michael, you got any comments? No, I thought it was a super meeting. We need a motion to accept the September 3rd meeting notes.
So moved.
Second.
All in favor? Anyone
Aye.
opposed?
Aye.
Okay, Deanne.
All right, well, the Public Health Policy Development Committee also met on September 3rd. We ended up, the board members that are on that committee ended up coming in by teams because there was a really big storm coming in, and so they let us do it by teams. I'd have to say it was difficult to hear the staff when they were making their comments or their presentations. So not exactly the best meeting as far as that goes. And I thought it was difficult to have conversation back and forth. So just my take on that particular team's meeting. Anyway, we talked a lot about the legislative agenda, and you will notice that you have another big packet with this committee, and Eric and Alyssa, I believe, will be talking about that here shortly. So let's see, we did have a request for a drive-through Kava kiosk. Clerk Snyder brought those to us. Really didn't come to a conclusion about that, other than the fact that no one should be selling Creighton. And Eric, anything else that we should make sure they know about that?
So and Melissa chime in. I know hopefully you're feeling it. So the request was to was for a drive-through kiosk to sell beverages that had both kava and kratom mixed into the beverage, pre-mixed into the beverages. So two different substances, two different issues. One is kava is an approved food additive, but people who are serving, who are licensed food service vendors,
It's not an approved food additive.
no, kava.
Oh, cover, okay.
Kava
Oh,
is,
sorry. Yep.
but they're not allowed to serve it with kava. They're not allowed to food serve. Let me back up. They're not allowed to serve food or beverages with the kava in it. People can purchase the kava separate and add it themselves, but it's not allowed to be included in the food or beverage. And these folks were proposing serving it already included, which makes them not eligible to be a licensed food establishment. Kratom is not approved for either. The FDA has classified it as illegal to sell in the US. It's not regulated at all. And so these folks had the double whammy of they wanted to serve kava that was already pre-mixed into what they were selling, and they wanted to serve kratom, which is just a no-no. Like, that's a hard no. Long story short is what this vendor decided to do is opt to not sell that particular those particular products in their drive-through hut, and so they aren't an establishment that we can license.
What are those two additives?
Kava?
Yeah, what is kava and what is kratom? Why
So,
do people want it?
yeah, so Melissa's gonna actually, you guys have a information sheet on kava and kratom in your packet, so she'll touch on that for you.
I think the big thing with that is that they wanted to sell it in a keg, and that is what is considered our jurisdiction, is that it's being handed as an open beverage to a client or to a customer. What they have opted to do is sell it in prepackaged cans. And if you sell it in cans and no other product in your establishment, in this case, literally a shack on Broadwater, is an open type of food item, then you're out of our jurisdiction. And so that's the distinction, is they're going cans versus keg.
Question. So if it's out of the jurisdiction, can they do it anyway? Or, and we're just not regulating them, or?
They're not a licensed food establishment, so we don't have any authority over their
So
operation.
they can do whatever they want.
No, they have to get a business license and be in compliance with the city and county's business operating requirements.
And does the city say you can't do that?
No,
So they can do whatever they want?
Yeah. Just to clarify, we have to be careful with the use of the word illegal because both substances are legal substances.
Yeah.
It's not like, people are selling something that is in violation of the law necessarily. Because our focus is on the food and beverage and on licensing and all of that, there are restrictions in terms of what we can and can't do. Both substances are to varying degrees of concern to public health and of concern to, a lot of organizations, but there's a whole lot of upheaval and gray area regarding each substance, again, to varying degrees across the US. Because the FDA has not particularly said they're not willing to take a hard line stance on it. Kava is a little bit more prevalent across the United States. My favorite is I went to get tea in our cupboard the other day and we have a kava tea up there. I mean, it's sold in grocery stores and whatnot. But how it's used and how it's being packaged and how it's being sold, that's something that public health is keeping a really close eye on.
Kratom is a little bit more of an issue. You know, there have been some courts that have actually said folks using it even for addiction issues and whatnot are in violation of restrictions on substance use and whatnot. But again, it's not something that is in and of itself illegal. So gray area, one that our folks are brilliantly navigating and trying to figure out what we can and can't do, and working with the city and the county. And right now, more so educating people, because whether or not it's legal, it's certainly of concern. And so making sure people understand that there are health risks associated with it.
But so basically, I'm just kind of wrapping my head around. So these people are like, okay, we're not going to do, they're not subject because they're not food and beverage. And they have, you can get a business license because that the business license piece doesn't cover that. And so they can pretty much,
They're basically operating like they're a smoke shop at this point.
yeah.
I mean, those substances are sold at gas stations and all sorts of places and prepackaged, you know, like all over the place.
Just like you can go and buy bath salts and spice and that kind of stuff in a gas station.
It's like a large.
Yeah.
Welcome to Montana.
Yeah.
The good news is they're going to be good business partners and practice on our and these substances are out there. And Melissa will tell us some more. Basically, kratom is a root, comes from the Pacific Islands, taken for calming, its calming effects, right? It comes from a Southeast Asian plant. It gives folks a little bit of calming sensation, a little bit of energy. The kratom is more of a risk as an unregulated substance because it actually acts on your body's opiate receptors. And so it acts as an opiate, like a fentanyl, like other illegal substances that are out there. And so these things are getting ahead of policy and regulation. They're getting ahead of government, and their uses and their unique marketing is catching on as designer drugs. And we, as public health officials, need to be aware of them and understand their impacts to the community, understand the negative outcomes they can have on patients who may have tried to switch, have opioid use issues, and have tried a harm reduction approach and tried to switch to a kratom substance without any sort of regulation or oversight or medical advice, and it's harming people. And so we're trying to get ahead of that, trying to educate the community about the dangers of both, and understand where there are benefits and how to help the benefits outweigh the negative consequences.
So it's a legislative issue, basically. But there's a smoothie shop, you're saying, sort of?
No, they're
No.
just selling cans.
It's like walking into the
Yeah.
gas station and grabbing a can.
Specific to the kiosk, right? We do have kava shops that we do inspect that are selling it.
But this is a lot, you talk to law enforcement and the synthetic things that they're coming up with, they trying to stay ahead of this is crazy. And you talk about gas stations and stuff like that. They're selling stuff that is doing stuff and nobody really knows where it's coming from, or, I mean, it's a crazy game trying to stay ahead of this. That it's scary, especially law enforcement trying to figure out what they're on. So.
This would be a good time to talk legislative session. Yeah. Okay. I have props this time, friends.
I'll look at it in the upcoming session.
They overdose on
So
it?
Deanne, any comments on the suicide prevention plan?
Just again, that it's not any information. We'll chat a little bit later on. We did, plan on not having a meeting in um, October. We will meet again in November, and we're asking to change that until the week after the November 5th, because of the election is on the same day that we would be meeting, and it'll be nice to know when we meet, at least who our representatives
Might be.
might be, state and national. We did talk a little bit about the, what they call the dirty dozen, the restaurants without licenses. So we talked again about prioritizing the scores and it's non-compliance and where people can actually find that on the website. That's just a very, very brief what we discussed. And so, Melissa,
Great.
what?
So first, I'll say thank you for getting vaccinated, everybody. I am immunocompromised. I basically don't have an immune system due to a very rare disease. And so I appreciate people getting vaccinated and donating blood. So today we're going to talk about 4 more topics. These are all really relevant to the areas of the organization that I have the privilege of overseeing. And doesn't mean that I am the expert, right? I just get to be the figurehead representing the awesome work of the team. The first 2 are somewhat linked. So secure firearm storage. And for those of you on Teams, I actually distributed gun locks to those in person. And if you would like one, let us know. We'll get it to you. Secure firearm storage and suicide prevention are obviously related, but they are not synonymous. Oftentimes in Montana, we talk about firearm storage through the vein of suicide prevention, but we also know that it's a leading cause of unintentional injury among youth. We have more firearms per capita than any state. And we have more, I saw in the news today, we have more firearm manufacturers per capita in our state as well. There's going to be a new technology firm, I understand, that's opening in Billings or in the Yellowstone County area that actually works somewhat on safe storage. So that's exciting. The talking points that I've provided for you really relate to the burden of firearm deaths within our state. I did realize there's a typo on the first talking point, so I'll correct that and send that out to you. But in Montana, firearms are the cause of death for 29 or 23.9 people per 100,000 residents. We have the 9th highest gun death rate in the nation. In the US, half of all suicides are by firearm, but in Montana, it's 60%. It goes up when you look at veterans, and it goes up significantly when you look at youth. Part of that is that it's a very effective legal mean, right? There's no hesitation, there's no gun locks prevent the suicide because it causes a pause to really think through what you're doing in the same way that locking medication does that as well. In the 2021, the legislature allowed anyone 18 or older to openly carry a firearm without a permit. They also amended our laws to allow concealed carry throughout most things, with the exception of federal buildings, courthouses, schools, and then of course some places can regulate that. It does still prevent people who, if you're not allowed to carry a firearm, you're not suddenly allowed to now. We also don't have a law, like many states, that imposes a penalty on someone who fails to secure a firearm and leaves it accessible to an unsupervised minor. So a lot of states are looking into liability laws, basically. How do we make sure that people are being smart in their own choices so that inevitably if someone gets a hold of it, commits a crime, commits a murder, that there's some sort of intended responsibility. And I think we're gonna see how those court cases play out with some of the parents that provided guns to school shootings. we don't necessarily have a specific law that we're watching with this upcoming legislation to tell you about, just to be aware of kind of what the status is within the state, to keep an eye out. We are not trying to take anybody's guns away. That's not the role of public health. Our role is to make sure that people are making smart, informed choices. And unfortunately, given our other issues like suicide, mental health, just the prevalence, we know that that's not happening. For those here, just to kind of give a little explanation, these gun locks we purchased using funding from the state that was approved via HB 118 in the last session. We provide them throughout the community, primarily through our Veterans Navigation Network partners, but throughout other partners as well. This is a trigger lock, so it's for a handgun. And then this is more of a rifle lock, a cable lock. The VA and Intermountain Health are now distributing these. And so we're finding that we're going to start buying more of these just to be able to fill that need within the community. People, when we have had these at tabling events, have really appreciated it because they recognize we're not trying to tell them how to live their life, what to do. They really do see it as, oh, I have fun hunting firearms. This would make me feel better when my grandkids come over. Are there any questions on the firearm piece? Yeah.
If a person in the community wants one of these, they can come here
Yeah.
at no cost.
Exactly. Yep. They just let us know and we track it so we can report it to the state what we're doing.
Where do they go?
We prefer that they would probably call us, just at the public health general number, just so we know and we can make sure it's available, but they can also just show up to this building and we'll run down. So we can do it in batches as well. Trying to think, that made me think of something else, but yeah, it's a fleeting thought. So
You have to give them their name though, to get up that.
no, we just give them out to whomever wants it. And that, part of this, right? You can use it, you can pass it along to someone if you like. You can always give it back to me, but I would love it if you could pay it forward and use it as a talking point as well. They are about, I want to say these are about $12 a pop. These are a little bit cheaper. And so we do say, going into this bike block, it's actually not that great of a bike block. We did have that issue with some of our initial cabling events. And then we're also working with Dr. Shay Saunders, one of our residents. She had opted to do the public health track as part of her residency. So she's actually doing some secure firearm storage workflows in the clinic and is going to be helping us get it incorporated, not into just we're trying to get it into the Medicare and well women visits, not just the child care visits, because those are the ones that it has historically been built into. Anything else on firearms? Anything else that John or Eric you would like to add to that? Try to toe a really fine line. It's like safe storage with cannabis products. We're not here to say, yay or nay, that's your business. We just want you to do it safely. So, in terms of suicide prevention, I provided you the entire strategic plan for suicide prevention. I realize it is a lengthy document, but they are seeking public comment for the next month. And so I thought it was valuable as interested members of the public and the leadership of this organization that you might want to check that out. And if you have thoughts, please let Carl Roston know. I don't know if anyone here has had the opportunity to meet or talk with Carl Roston, but he is a huge asset to our state and our state health department. He's a service member, an LCSW, and he's led the suicide prevention work in Montana for years. What I did is I pulled the top 3 strategic priorities out of that plan that we are seeing as being the most relevant to our work. The big ones being, let's really focus on resources for reducing access to lethal means. Let's push that conversation. It's not comfortable, but as I just discussed, it's really, really important within our state, and we need to not shy away from that. We also need to strengthen our crisis response system. So thinking about the mobile crisis unit that's on pause here in Yellowstone County, people need to recognize that as a key part of our suicide prevention efforts as a state. I worked in Portland prior to working here at a Native nonprofit. I can't tell you how many times I called that crisis response system, and those social workers saved a life. because I had clients in front of me that I knew needed that support. I would love to see that here in Montana. And then the last piece is really working on our data quality as it relates to suicide prevention. There has been a small effort to train coroners on how to better identify suicide cases, how to address familial pressure to not rule things as suicide. But also there's a national movement to start including any firearm related injury as a reportable disease. So just like we report syphilis, we report influenza, we report pertussis, anytime a firearm is involved in an injury or a death, getting that reported to local health departments for investigation, because that allows us to do some root cause analysis on the prevention side too. It might have been an attempted suicide, but then labeled as an unintentional injury, if that makes sense. So that will just help us better understand the issue. Are there any questions on suicide prevention, comments?
Question about the discussion in general.
Yeah.
And a politically, we're talking about gun laws.
Yep.
The politically sensitive issue around guns is gun control.
Mm-hmm.
Many permutations of definition. Has any, do you or others know of a public health department taking a position on gun control?
I know the I don't know about a health department, but the APHA, the American Public Health Association, has for years and years had issue papers on gun ownership in the US.
And the APHA, the American Public Health Association, has taken and published many different studies on gun violence as an overarching, so impacting urban communities, impacting youth, impacting other cities and states across the country. As the U.S. Surgeon General has also declared firearm violence as a public health crisis. So again, not stepping into a political debate on whether someone on gun ownership or the Second Amendment or assault rifles or any specifics to that effect, but the fact that remains that firearm violence, suicide by firearm, youth access to firearms still remains a public health priority to ensure life, health, and safety in communities across the country.
I think it's also important to note that public health is a very data-driven field, right? We don't make decisions based on ideals. We make decisions based on evidence and data. And part of the challenge with that, we'll talk about with Agua Kratom as well. Part of the challenge with gun safety is there was a federal rule within the last decade prohibiting research into the health impacts of gun violence. And so the current administration has backed off of that, but that's part of the challenge is when you prohibit or make it challenging to understand the issue, local public health is somewhat handicapped in knowing how to navigate. I will say public health professionals across the nation, I'm proud to be in the field, are very creative, right? And so we'll talk about it through the means of suicide prevention. We'll talk about it through the means of hunter safety, right? It's part of our culture. I grew up with guns. I had my own gun. It's not about that. It's about keeping people safe.
For a minute there, I thought you were talking about bean counters, talking about being data-driven.
Oh.
Then you said creative.
Yes. Yeah, you can be both, right? Right brain, left brain. I mean, Gabrielle Giffords, Congresswoman Gabrielle Giffords was my congresswoman. I'm from Arizona. I had almost attended the Safeway event, but I happened to be visiting a boyfriend in Bozeman at the time. It's very real, you know, and we as a society can't kind of choose one or the other. And that is objective, data driven. That's not an opinion.
And it's part of our public health mission is to prevent economic damage from
Yes.
health impacts. And gun violence costs the United States about $560 billion annually. And so it's that societal cost of assault or injury with firearm, the long-term medical care, the rehab expenses, the criminal justice system resources, lost wages for folks, worker productivity, diminished quality of life. The list goes on of how do we maintain a high quality of life for folks in our community. And so it's through education, it's through training, it's through safe storage of whether it's a firearm or a medication or whatever that may be. It's about prevention and how do we prevent things from happening and prevent negative outcomes for people's lives.
And I know there is some, again, with the creative research, there is some research going on about the economic burden of school shootings, in particular on the adverse childhood experiences, the subsequent behavioral health, and then the cost to schools to implementing somewhat reactive security measures. So we're just starting to kind of understand.
Thanks.
Yeah. Anything else on that? Okay, designer drugs. Here we go. So designer drugs, everybody in your packet should have received a fact sheet that our wonderful staff have created. We have fact sheets on other specific designer drugs, and the Public Health Policy Development Committee has had presentations, which I believe has been forwarded to you, on specific drugs throughout the past year. Ozzy and Kratom are obviously our key focus right now. But this designer drugs at a glance fact sheet is intended to educate you, but we'll also be using it throughout our community in the coming year. Because what we're finding is that this really is a new topic that we're wrapping our heads around. And to be able to be nimble, we need to think about policies that would address designer drugs as a whole. Because by nature, they're just going to keep coming and coming and coming. Basically, in essence, they're drugs that are created in a lab to mimic an existing drug that we're already aware of. Because they're created in a lab, they're not subject to the regulations that existing drugs are because they're not named, right? They're not known. We can't regulate something we aren't really sure of. They also tend to pass with bright flying colors any drug tests because drug tests aren't designed to capture these genetically modified substances. And so when we talk to the DUI task force, they'll say, gosh, we wouldn't even know how to do a CAVA kratom test. Like everything involves literally going to the jail to do blood testing, and then you don't even know if the results are going to come back. What is going on there? They are often based on natural products, but we know that chemical modification can, just like vaping, it can introduce all sorts of harmful chemicals. It can also create different pathways for the drugs to interact with our bodies. And so that's part of what gives us pause is we really don't understand how these interactions work. We don't have the right antidotes to respond to them. And societally, we're really just kind of gambling with trying them. What we tried to do was outline some of the natural occurring substances against the designer drug, just to give you a sense of kind of what it's trying to mimic. As mentioned, K2, spice, Delta 8, those are all in all of our gas stations. We will occasionally just, get gas, get snacks for my kiddo, and I'll see that they are available. Kava and kratom are a little bit different because they're just sort of this no man's land. As John said, kava is a root that's turned into a tea. Because of this, it's often regulated as a tea house. That's not something that's a high level of concern. On the flip side, kratom is a leaf that's often ground up in a pill and a concentrate. The challenge with these is they're kind of being sold as harm reduction. Kava is often marketed as buzz without the booze. It's available to anyone in the industry. You're not supposed to provide it to people under 18 or 21, but we know that local shops are doing such. And there's no formal rules saying you can't. And so that's what's really difficult. And I know we've talked at the committee meeting and with Tina about, do we really want to be the first community in the entire world to set an age limit? Probably not. The challenge with both of these is that because they're poorly regulated, we don't know how they're being manufactured, what's going into the substances. We don't know about dosing, concentration. People are self-medicating, which always gives pause for any type of substance. And what really worries us about that youth exposure is it's normalizing this kind of altered state, right? One of our kava houses in town, they have family karaoke nights. They have free food for kids. If you bring your kids in on certain nights, they get free meals while you enjoy your kava and your kratom. We also know that kratom is being sold, and that's often the moneymaker. It's like lottery tickets and tobacco products at a convenience store. That's what's really enabling the business to.
What's the cost difference?
I believe, so the kava drinks are usually about $10. I've seen $5 to $10. The kratom, I'm less familiar with that. I'm trying to think, I saw a menu not too long ago. But yeah, you know, designer drink, maybe think of it as a cocktail price. I don't drink hard liquor, but the big part with both of these, though, is that because people are self-medicating, what we're seeing more and more, particularly with kratom, is they're presenting their own health issues. Our healthcare providers are being caught a little flat-footed. Parents are being caught flat-footed. And of course, as we just said, we're being caught flat-footed. People are coming to us asking, what do I do? Is this okay? I'm saying, well, we don't really know. No. Would you try something you're not sure about? We have heard many anecdotes from different providers. Dr. Hong, one of our residents, shared that rotating through the dental clinic and someone was just struggling to respond to some of the dental anesthetic that was going on. It turned out that they had a high dose of kratom on board. And they keep like, I didn't even know what that is. So I'm having to really rapidly try to educate myself in real time. My husband's an urgent care provider, and he said he'll have people coming in trying to get off of opioids that are having, 30 doses of kratom. He's like, I have to ask, would they have been better off just using an opioid versus trying it? So definitely in no man's land. In terms of the actual policy agenda, we just feel like there needs to be rules requiring consumer advisories, age limit signage. So maybe we're not going to pass an age limit, but we're having an advisory that says not recommended for children to consume. And then point of sale education. So one thing the Cannabis Control Board did is they require point of sale education in use dispensaries, knowing what you're doing, what you're consuming, the importance of safe storage, what your limits are. To go a step further, we really need regulation at both the local, state, and federal level on regulation, manufacture, consumption, distribution of these businesses. As we said, if it's not a place that we're operating, that we're licensing, you can't go in there. And the Cannabis Control Board, they deal with cannabis. And so if we had more policy to kind of extend their authority, they might be able to do some of these quality checks and see what's really going on. Are there any questions, comments? Yeah.
Are you aware now of any proposed legislation affecting this? You mentioned maybe the need for more regulation. Is there some group that is actually going to propose legislation?
That's a really good question and point. So what I have personally found is this is being perceived as a very Yellowstone County problem. Our staff have reached out to other counties within Montana, as have I. And they're saying, oh, we don't have this in our community. They're not aware that they have it in their communities. We actually just got a small grant from the state health department to do education. And we're finding that we're actually educating them on what it is. In the last legislative sessions, there was proposed legislation to regulate this, but it was shot down in part because of supporting business in our state.
Who brought that or who supported that, you know?
I don't remember off the top of my head. Either of you guys remember? Yeah. It is.
Any other questions from Melissa? Melissa, great job.
Thanks. I'll just say you guys have the licensed establishment fee change document here. Montana Environmental Health Association will be proposing a fee change at the state legislature just to catch up on the true cost of our sanitarians doing the work. Right now, most of that fee is coming from public or the levy dollars. If they were to increase the fees in Yellowstone County, we would be able to free up those mill levy dollars to support other public health programming like designer preps. So, yeah, thank you very much.
Thank you, Melissa.
Yeah.
Thank you.
So just to clarify, at their last board meeting, we asked if those Montana legislative public policy agenda items be brought to the full board. And so that's the beginning of that information.
So, I already filled it out.
Okay.
We need to accept the September 3rd meeting note. Move to accept.
Second.
All in favor?
Aye.
Anyone opposed? Okay, the governance committee. We spent considerable time working on the self and operations assessment, which is being passed out. It's also available online. And if you all could get that filled out within a week, and then those who don't get it filled out, I will start nagging.
And so, yes, we have the self-assessment online. Please don't fill it out on paper. We're just sharing it for your review and looking at, so that you can talk about questions. We're going to talk about 1 or 2 questions again today at governance committee and just get it right. And as soon as we get it right, Carrie will be distributing the electronic copy for you to fill out online.
And it did not take very long to fill them out.
No, takes really short amount of time. You'll be able to provide some comments, information on the self-assessment for you as a board member. And then the second assessment is of board operations. And so please do your best as you take your time to fill this out. I just want to say the second question there on how likely are you to recommend is a traditional net promoter score. So anything 8 to 4 is a passive response. So I hope that you are active in your response. Just to key you in there. And if you're really unlikely, let us know why. We want to know your true trusted feedback. So the questions are there. We'll have some updates done at the governance committee meeting this morning, and then we'll send it out to everybody. And we will also send reminders so that we have feedback by the time we come together next month. Thank you.
And John, you had some thoughts on the nominations.
Yeah, so we're also going to talk through nominations and nominating committee this afternoon because we have, or sorry, this morning, because we have a few folks, a total of 4, who are scheduled to roll off or already have rolled off the Board of Health. And so we'll be discussing several individuals and folks who might be interested in providing board service. There is a question on the assessment or survey for you to take a minute and think about folks around the community who might bring skills and expertise to this board. And so please take a moment and think about that. And we'll present those individuals, should you nominate anyone or bring a name to our attention, to the nominating committee for consideration.
Good. So we need a motion to accept the August 22nd meeting note.
Second.
All in favor?
Aye.
Any objections? Okay, on new business, we need to approve the emergency CEO succession plan. I think it is very well outlined in the materials you got. Nice thing about Megan is that she's already the assistant public health officer, so that's an automatic.
Jackie, Deputy.
Deputy, I'm sorry. Yes, boss.
That is a very clear legal distinction.
Yes. So, do I hear a motion?
I move we approve that policy.
Second.
All righty, all in favor?
Aye.
Any objections? Good. Eric, you're up.
All right. Maybe I'll just come and sneak in next to you there. So we did a presentation for the foundation board, actually.
Why don't you go up front?
All right.
And I'll share your slides here, Eric, too.
I didn't want to.
No, we want you to be the center of it.
So we did a presentation for the foundation board, so this is going to be a little bit of duplication for a couple of folks, so sorry about that. But John Doerr asked us if we could do this for all of you. So this is really talking about a few things. One is the importance of educational attainment on future life outcomes, how school-based health centers generally impact or can support good educational attainment, and then a little bit about our internal program. So I wanted to start off with a little bit of a trivia real quick. Because I think we're in a room where we probably have generally folks who are like, you know, high achievers and high educational attainment. And I know for me, every time I see this stuff, I think, can that really be the case right now? So guesses on what the graduation rate, you can't answer this question. What's the graduation rate in our school district? High school? High school graduation rate.
64.
83.
You're closest. So right now, it's about 85% on average across all of our schools. I will tell you, there's disparities in our schools. Senior high is lower, West is higher. Imagine, right?
Nationally, what is it?
I don't know that. I just looked locally. You know, Deb?
I don't know. Probably very similar.
I'm sure Google knows. Yeah, we can probably chat GPT that, but
She's checking it.
Yeah.
recently, did anybody see the Billings Gazette article that they put out in August, at the end of August? It was titled "Reading and Math Proficiency in Billings Middle Schools Remains Stubbornly Low." Did anybody see that?
Yeah.
Yeah. Do you remember a few of the stats that they had in there? So if I scroll down here real quick,
87%, by the way.
yeah, is that national?
National.
Yeah. So again, disparities across our schools, but anybody want to take a stab at, let's say, middle school proficiency in math? What percentage of our students currently are testing proficient at a middle school level in math?
Below 50, wasn't it?
Very much below 50.
60.
No. So the highest school was Ben Steele, and they got 46. Our lowest school in our district was Medicine Crow, and they have 15% of their students testing proficient in math. And reading is slightly higher, but still not great. So Ben Steele, again, is the highest with 49% of the students testing proficient in age level appropriate or class level appropriate reading. And our lowest one is Riverside with 21%. And then just some other local school district data that was in that report is on attendance. We don't have a single middle school in our district that has over 42% of students with 95% or greater attendance. And so that's basically meaning that over half of our school students And in some schools, almost 75% of our students are probably missing more than a day a month of school. Probably closer to 2 or 3 days a month of school on average. So I just wanted to kind of ground us in that data, because I think for folks who have achieved high educational attainment, and you think like, oh yeah, everybody graduates, right? But it's just, it's not the case. If we've got maybe 4,000 high school students at any time in our school district, maybe roughly, maybe a little lower than that. 15% of that comes out to 600-ish of those kids we can anticipate won't be graduating from high school.
So I got to ask.
Yeah.
So if we have 83% graduating from high school, you did middle school proficiency. Do you have any idea what the proficiency is of those 83% that are graduating?
I didn't.
In math? That's kind of scary.
Yeah. Yeah. I'm sure the data's out there, like what percentage of kids who are graduating are meeting those objectives, but I didn't look it up for this, but.
Make kids struggle in college.
Right. Well, being a business owner, I'm trying to give change back. If you give them $1.05,
yeah,
trying to give change back, they could not figure it out. You added the 5 cents because it was $1.03 or whatever.
Right.
Threw them off.
Yeah.
Get dependent on the machine.
Yeah, the machine does it for them. Yeah. If it doesn't do it for them, they're lost.
And I should also mention that Joan and I did this as a tag team. So Megan, help me and chime in if you have anything on this. Megan, if you don't know, actually provides care at our school-based health centers pretty frequently. So she's gotten the firsthand knowledge. So there are a few educational attainment milestones that can be pretty predictive of future outcomes. So the first one is kindergarten. So we know that kids who enter kindergarten unprepared for kindergarten, so this is our youngest students, have a harder time getting into 3rd grade reading level attainment. When you get to 3rd grade, there's a whole bunch of data about how reading proficiently at a 3rd grade level by 3rd grade can be a predictor of whether or not you'll graduate from high school.
What does one do to be prepared for kindergarten? Like,
Go ahead, Megan.
So, this is kind of the whole concept behind our Parents as Teachers training program that we have here in public health and our family nurse partnership, these home visiting programs. A child's first teacher is their parent or their caregiver. And there's actually links with how many, and there's some debate that has come out in this literature, but how many words a child hears by the age of 3 correlates to their readiness for kindergarten and these other, and then their literacy level. And so really a lot of it comes down to what is the support that a young family is getting when they have a new child. Are they reading to them? Are they talking to them? Do they understand what is appropriate for their child's level of development? And what are they doing to help build their baby's brain? Because the majority of brain development occurs between the ages of 0 and 3. And so we don't even get them into school, until 5 or 6. Right. And so a lot of focus in the AAP world, in the pediatric world, is really focusing on how do we support, these young parents or whoever the caregiver is, because many of these kiddos are, have someone else raising them besides the parent. How are we helping that family to support that child's development?
Are they supposed to know their ABCs? Are they supposed to be able to read, or what are the?
By the age of, by what age?
Kindergarten. I think it could.
Oh, I don't know exactly what the most kids don't know how to read most kids don't know how to read by the age of 5, but they certainly have heard a lot of, there are disparities in socioeconomic groups by how many words a child hears. And that's reading and conversation and, lots of things that I think many of us do naturally with babies and our, interaction where you talk to them, play with them. And that isn't, when you're a family who's under stress and you're just barely surviving, you're not sitting on the floor and playing blocks and reading to your child, right?
Yeah, and the hobby
Yeah.
kindergarten is socio-emotional development, so have you been exposed to other kids so you know how to play with them? Like just real basic, like early childhood development stuff that's missing in a lot of kids before they get to kindergarten. So moving on to the next slide, just to kind of keep us going here. There's the third real predictive milestone in educational attainment is graduation rates. So kids who drop out of high school, and there's ranges in this. I went on the lower end of data that I saw. 3.5 more times likely to be arrested than their peers who graduate. The Bureau of Justice Statistics, so this is federal prisons, estimate 41% of the inmates have not completed high school. And then there's a whole lot of data also about kind of disciplinary practices in schools, and the fact that these zero tolerance disciplinary processes that promote expulsion often do more harm than good. So they disproportionately impact students of color, students with disabilities, and LGBT students. The ACLU, for example, put out data that said students who are expelled are up to 10 times more likely to be arrested or face legal consequences. And so we'll talk more about that in a minute. But anyway, kind of just putting that all together.
And so, I just have to say, SB2 is making amazing strides.
Yes.
Dr. Garcia and his team on utilizing all of this data, working across our community, providing special opportunities for learning, alternative learning environments, and the Washington Center program and other programs that are happening across the school district. Thank you, Debbie, and thank you, SD2 folks. This work, what we're focused on in the health centers, is going to be so complementary to those efforts and strides that they're making.
So just kind of putting that chain together, if we can get our kids in kindergarten ready for kindergarten, they've got a higher likelihood of being successful at reading at a third grade level when they're in third grade. And we know that if they can do that, they have a much higher likelihood of graduating from high school. And if they can do that, they have a much higher likelihood of socioeconomic success and avoiding criminal justice system involvement. So how do school-based health centers help with this? So these are ways that school-based health centers have been proven to support educational attainment. One, some of these are pretty obvious. Some of them are a little more, diffuse and kind of relate to how we partner with the school in the whole package of things that schools are doing to keep kids activated in school and healthy so they can learn. So these are all things that are, school-based health centers have been shown to impact nationally. So what is the school-based health center? So it's a shared commitment between the school and the healthcare provider. They are a flexible model that is built to meet the needs of individual students and individual schools. So, the needs of the kids in West High might be very different from the needs of the kids in Orchard Elementary School, or the needs of the kids in Medicine Crow Middle School. So the services can be flexed to meet the needs. What we're finding right now in our school district is very high needs for behavioral health services. So moving along.
That's true with what they see nationally too.
Yeah.
So nationally, the need for behavioral health services exceeds the need for medical. So a number of the school-based health centers in Montana only offer mental health services. Ours, we offer full spectrum, but that's sort of that and dental.
So do we keep track of why students come in?
Yeah. Yeah, I mean, it's a medical clinic.
numbers,
So,
okay.
yep, we have numbers, we have what the kids are getting diagnosed with, the types of services they need and are getting. This is the scope of services that we provide in our school-based health centers. So, full service primary care clinics, behavioral health, and some preventive dental work that we do.
What do how do the school nurses relate with that too? Is there some duplication?
No, no. So we are, we operate under doctor's orders just within the school per patient. We don't have a medical provider to oversee the nurses in the school district, so we can't operate. We don't have any supervision. So we are operating our own license in the school district with the students that we care for. And that's why we have to get doctor's orders. You know, it could be from anybody in the community, but we follow those specific orders for the doctor. So we don't interact with the school base. We provide information and education that is available. And that's getting better. I think that's been a big deal. It's not people not knowing that that's available and how to even access the system.
So we can go ahead to the next slide. This is our oldest school-based health center, Orchard Elementary School. We've been there since 2015. You can kind of see some information on how we've grown over the years there. Orchard has medical and behavioral health services. Moving along, our second existing school-based health center is Medicine Crow. Medicine Crow opened in December 2017. Again, you can see how the needs in that school have grown over the years. They also have medical behavioral health services. And somebody mentioned this earlier, I think Megan, you did, that we're getting ready to open our next school-based health center in senior high school. And so some people ask, like, do these make money? You know, money is kind of like our secondary goal here. We're in the schools to keep kids in the schools and keep them healthy so that they can learn. But yes, once we start up a school-based health center, our existing school-based health centers are financially self-sufficient. And so it is a model that can financially sustain itself. And so
After 2 years, right?
Yeah, and after, so we ran, I mean, there's a long history that those of you who've been on the board remember from when we started Orchard. We lost money for a number of years at Orchard, significant amount of money. But part of that was because we had to balance when we were there. We initially started with close to a full-time presence there, and we've ratcheted back significantly. Behavioral health, we have there full-time. Medical, we only have there 2 half days a week. So once you right size your services to the demand, you can get it to be, you know, really, you know, revenue neutral or even positive. But you got to right size it to the need of the population. So it takes some time to sort that out.
What are the sources of revenue?
so some grant funding, but mostly patient generated, just like the clinic. Yep. Mhm.
Majority of these students that we'll see are Medicaid eligible.
Yeah.
Okay, so
And
it's
has
from the
maintained Medicaid.
provider, patient pay.
Right.
They have our sliding fee scale, everything that we do here.
So this is senior. It's opening up, like Megan said, probably late October, maybe into November. So, so a big part of what makes school-based health centers is collaborating with the teachers, the school administration, and we do that on a regular basis. I mentioned the impact of zero tolerance policy, disciplinary policies that promote expulsion. When we set up a school-based health center in a school, a lot of what we do is work with the school administration around reevaluating those policies. We work with the school administration and the school nurses to promote access into the school-based health center. We have kind of a school-based health center linked collaboration with School District 2 called Project Aware, where we work with teachers in the classrooms to teach them how to work with children who are exhibiting emotional behaviors that make it challenging for the classroom to learn or could impact the classroom environment. And there's tiered responses that people are trained on how to kind of work with kids. And Megan can probably talk a lot more about just Project Aware. But it's basically an escalated approach to working with the kid in the classroom, to all the way up to, we have a behavioral health provider in the school that starts working with those kids one-on-one if they're having real behavioral challenges that can't be handled at lower levels of intervention. And then the next couple of slides are just some things that we have done. Get out to all the school fairs that they do. We also do, we try and not duplicate, but supplement the education that school nurses are doing. We know that our school nurses are spread real thin. And so, this is Miss Moeller up here. The kids love Miss Moeller. Yeah, do the behavioral health providers and the school counselors work with each other to supplement each other's work. So we know that the school counselors, because of recently passed laws, have a lot of limitations on what they can actually do. So a lot of times school counselors will pass kids off and over to our behavioral health providers in the school. And conversely, if our behavioral health providers working with the kid, they can kind of let the school counselor know to kind of keep an eye out for what's going on with that kid. And I think and then as kids get a little older, we have public health and school-based health center and school kind of triad partnerships with things like React Clubs, which is a tobacco use prevention club in the schools, health clubs, some of those kinds of things. So we want to continue to build our volumes. Our next kind of going into senior, one of our goals there is to pretty quickly work with the staff that are going to be working in the school-based health center and the school administration to develop a student advisory or a student health club that can work with those folks to kind of keep us on track with what services the students of those schools need and want. Let's see. So just some staffing goals we have. And then ultimately, I think, I think schools are where we need to be for all those reasons. It's such a crucial time in the development of people's lives. And ultimately, I think we'd like to be to a point where we've got a school-based health center in minimally every middle and high school in the school district. So that's that. Any questions?
The people providing behavioral health care in the schools, what level of practitioner is that?
They are LCPCs or LCSWs.
It's,
Yep.
And again, working in concert with school counselors who are there.
Yeah.
Who aren't licensed to provide that in-depth behavioral health treatment and counseling.
What I will also say, though, is that the providers so I lead the providers who are there. Initially, when we started the school-based health center, we had a collaboration with Billings Clinic Psychiatry. That for a whole host of reasons didn't work out. However, all of our providers, so I've done a lot of extra training in behavioral health and developmental issues with children, and all of our PAs who work in the school have had advanced training in behavioral health issues. So we actually manage from a medication standpoint and a diagnosis standpoint, manage a pretty high level of behavioral health issues. When it's out of our scope, we can refer them to psychiatry, but we do ADHD assessments, behavioral assessments, we manage anxiety, depression, all those things.
So referrals to an MD psychiatrist would be clinic or private psychiatrists?
So, we have an adult psychiatrist here at RiverStone. We have a behavioral, we run a behavioral and development pediatric clinic that I oversee with the same providers that are in, that are in the schools. If it's beyond, so like kids that have psychosis, kids that have been on multiple medications and are still having multiple admissions to the psychiatric unit, those we refer to psychiatry. And that is typically where our psychiatry resource, our pediatric psychiatry resources are slim here, but we have Frontier, which is Dr. Arzubi. It's a telehealth. And then there are some psych nurse practitioners in town, and then Billings Clinic is rebuilding their pediatric psych.
Leanne, you had a question?
I'm just wondering if there's any in the long-term plans going into the rural school districts in Yellowstone County, since we are in Yellowstone County.
We've looked at that. Part of the hard part about the rural schools in terms of a bricks and mortar site is just the size. I mean, some of them only have 50 students in the whole entire school. And, you really need a certain size of students to make the time commitment out there. We have talked about with some of our conversations on how we want to use a mobile unit when it comes down the pike. That those rural schools would be great hubs for us to go out to and use as kind of service hubs where we park the thing, but kind of act as a dual resource to the community, but also to the students in those schools and the smaller schools like that. So
Nationally, that's a model. I mean, there are lots of school-based health centers that work out of mobile units. And so you can still be a school-based health center, but not be, there are benefits to being inside the brick and mortar, but that also is not always practical due to size, due to, cost, and a whole security, a whole host of things. So,
thank you.
So we're out of time and we are adjourned.